Great. Thank you so much, and thank you for joining me tonight. So who am I? I'm coming to you from New Jersey, where I am in private practice. I am a board certified pediatric dentist and orthodontist, and I completed a craniofacial fellowship at NYU at the Institute of Reconstructive Plastic Surgery. I'm also an assistant professor at NYU and a board member of NYU's Center for People with Disabilities. So what are our goals for tonight? We're hoping to discuss interproximal reductions, and you'll understand exactly when to use them, what to watch out for, and how to properly achieve all of our goals. And we'll go through this not only just in theory, but also reviewing some cases. So incisors really provide us with a beautiful smile. And we know that not just the size of the teeth or the shape of the teeth or the color of the teeth are what guides us to having beautiful teeth. We know that the social six, as we call them, the anterior teeth, can vary in many different ways. And we have lots of analyses to take a look at this. We know that the gingival architecture, the shape, the contact point, and all of those, and color, and all of these different things lead to the art of creating a beautiful smile. So what are some of the tricks of the trade that bring us to having the best possible smile? We know patients sometimes come in and say, oh, I don't like how flat they are, or how sharp they are, or how they look. And this is just another way to learn how to achieve the best aesthetic results. Having some of those teeth that are not the right size or shape really do change how our smiles look. Now, we don't all need perfect smiles. We know that we have asymmetry between teeth, and we can have some changes in color. And gingival architecture plays a part as well. But what do we do to achieve that ideal? But also, how do we deal with teeth that are not proportionate? And how can we create that wonderful proportion? The laterals have the most variation in size. And while sometimes that can create a big problem, oftentimes we can camouflage them. But how do we have the best plan to achieve the best smiles? And it's not just from a restorative point of view, but also from an orthodontic point of view. And those two are not separate in different schools of thought, but extremely integrated. Sometimes we can have perfect shape, color, size, but it just doesn't look right. And that's because our contact points are off, or we don't have the proper gingival architecture. The dreaded poppy seed appearance, or the black triangle between teeth, either in the upper arch or the lower arch, can cause problems from prosthetics, even though from a functional point of view, things may fit perfectly well. Remember, it's not just the science, but it's the art and science of creating smiles that gives us the best result. And here we can see we're missing a lower incisor, and the teeth are beautifully aligned, but we have those black triangles, which nobody really likes. Now, maybe this happened because teeth were previously crowded, and as we unraveled the teeth, the bone underneath was not as strong, and we had a little perio issue. So when we have crowding that has existed for a while, we do have some bone loss and we have some perio issues. So it's not the uncrowding or the unraveling of the teeth that cause these black triangles. We're just exposing the bone and gingival architecture that we have. So how do we combat this? We have our Bolton ratio. We know that the upper tooth size should be 23% larger than the lower tooth size when we go from 3 to 3, or canine to canine, the 6 anterior teeth. And Spear talks about this all the time, but this Bolton ratio is kind of our golden rule that we talk about. We like proportions. If we go back to the Egyptians, everyone's talking about proportions. So this is something that we've known about for a long time, but how do we achieve it? So it's finding that science. And we know that the shape of the teeth makes a very big difference. We know that how we finish our orthodontic cases by doing some a little aesthetic recontouring or how we do our veneers can really change how somebody looks. We know that there's a feminine look, which tends to be more tapered. We know that the masculine look is broader and more square. And as we age, our teeth become flatter. And our young teeth have our mamelons. Every day, parents come in and say, why do my children's teeth that have just come in, why do they have those bumps? And we discuss what mamelons are and how we all started with them. What I find amazing is the middle picture on the left, the Hollywood smile, where all those incisal edges are almost aligned. That Hollywood look is really one that I personally don't find super aesthetic. I much prefer a more natural look. However, that is what is in vogue right now. Many patients are coming in, teens and adults, with pictures on their phones, and they take their two pictures and they spread them apart and they zoom in to show what they like or do not like about their teeth. And one of the things that it tends to be are the edges of the teeth, the symmetry between the right and the left side, and how those gums do fit together. And we can see this was a Daily Mail article that was what your teeth say about your dating personality. And are you mature and efficient, or are you calm and sophisticated? That's where we can go with just that smile. Apparently, your smile on your dating app profile picture can tell you more about anything than your write-ups. So people can be creative with how their teeth are. So when we think about enamel and teeth and recontouring to create these aesthetic results, we need to know how thick that enamel is. We need to preserve that tooth structure so we're not doing harm. Remember, as doctors, that's our first thing, do no harm. So we want to make sure that as much as we're creating beautiful aesthetics, we are not damaging those teeth. So incisors have a lot of variation in their size. We know the upper lateral incisor has the most variability in size. Those tend to be our peg laterals. They tend to be just diminutive, much more than centrals or lower anterior teeth having as much discrepancy. Now, those are very high profile teeth when it comes to our smile, so we have to know how to combat that. Sometimes we do composite buildups or veneers. Sometimes we leave spaces distal to the laterals and still have an aesthetic smile. Now on the lower laterals tend to be larger than the centrals. And when we did some histological studies, we found that it's not actually the entire tooth, but it's really the distal aspect is larger and thicker than the mesial aspect. So if we do start contouring, we need to remember that. We'd like to take more from the distal of the lower laterals from the mesial. We know that male teeth tend to be larger than female teeth, but it's not the enamel that's thicker. It's the dentin that's thicker. So don't think that we can be more aggressive taking off and trimming the teeth of males compared to females, because we can end up with some problems. Caucasian enamel is thinner than African American enamel, and so we do have a little more leeway of how much we can take there. So the studies have shown exactly what the averages are for our enamel thicknesses. And we can see that we have anywhere between 0.3 as the minimum to 0.8 for centrals. So in general, we say that our rule is 0.25 millimeters of enamel can be removed on the lower incisor, okay, from the lower anterior teeth. So that way, if we take 0.25 on each side of a tooth, we can gain quite a little bit of space, and we can use this space to help us gain our goals. So what is interproximal reduction, or IPR? It has a bunch of names. Sometimes it's known as stripping, slenderizing, reshaping. That sounds Slenderizing always sounds a lot more appealing than stripping or interproximal reduction. Patients can get very concerned when they hear reduction, but reshaping or slenderizing is kind of the kinder, softer phrase. But all of these terms can be used interchangeably. So what exactly is it? The exact definition is the deliberate removal of part of the dental enamel from the interproximal contact area, which decreases the mesial distal width of the tooth. So we are doing a permanent reduction of these teeth. And as you can see, all the way on the left-hand side, we have two teeth, and there's a black triangle there in between them. In the second picture, we can see two little lines showing where we treatment planned to remove part of that tooth. In the third picture with the green arrows, we slice or slenderize those teeth and then move those teeth together for a picture all the way on the right, which will show us a broader contact point and a more favorable periodontal condition, where the interdental papilla has filled in that space. So what are our guidelines? Our guidelines are that we can do this in between anterior teeth or posterior teeth. So in the anterior segment, it's 0.5 millimeters per contact. So 0.25 off of one side of the tooth and 0.25 off of the other side of the tooth. So you're not taking 0.5 from any one tooth, but rather going in between. Now remember, some teeth, the enamel is thicker, so it's not always a 50-50. Sometimes you may take a little more off of one side of the tooth versus the other. It's a case by case, but know your thickness. When we work posteriorly, the enamel is thicker. We also have more triangular anatomy. So we can take more. We can take 1 millimeter per contact, or roughly 0.5 per tooth. And this is how we gain a lot of space. Sometimes we do not want to extract. Or sometimes it's an adult where having extractions or moving teeth, or maybe we don't need so much crowding to be resolved with just a little bit, and then we need other ways to achieve it. And we have to watch out for the bone, so we may not want to expand. So this is where IPR comes in very handy. So what are our indications? One of the cases where we would use it is where there is a tooth size discrepancy. We know that there is irregularity between the right and left hand side, or right and left side of the dentition. So one central incisor will not exactly be the same size as the one on the other side. We also know that sometimes we have more tooth matter, canine to canine, on the lower arch than we do on the upper arch. So how do we achieve that proper interdigitation? How do we get those upper and lower teeth to fit together properly and have good aesthetics and good contact points if we have too much tooth mass on the lower compared to the upper? And that's when sometimes we may trim in between the teeth to retrocline or retract the lower anterior teeth and have better overjet and overbite. Being overcoupled or having too tight of an overbite and overjet can lead to some other issues. And so this is another way that we can do that fine tuning and really create those beautiful smiles. How do we determine if there is a Bolton discrepancy? Back in dental school long ago, we had calipers and we would measure them. We also had ways to predict the size of the adult teeth if we still had primary teeth. But now we have much better ways, which are more accurate than me reading one of those calipers. And on the Align ClinCheck, they will actually do all of your Bolton analysis for you, okay? And sometimes if you don't have all of those teeth, you can have the anterior Bolton analysis be calculated, and they can either predict or they cannot do some of the posterior analyses, but it's made it a lot easier. Another indication for IPR is when we have crowding. So by removing tooth mass, we can get these teeth to fit together much better. However, when we do have some crowding, we also know that we may have some bone loss there, which when we unravel those teeth, we will also have some dark triangles. So when we alleviate that crowding and create smaller tooth mass, we can get the teeth to fit. There is a rise of aligners being used today. And so alleviating this crowding with aligners makes it a lot easier. Now, in a case like this where we look at the lower teeth are almost tipped inward. We can upright the teeth to some extent, but we cannot resolve all of that crowding with that uprighting. So it really helps us get the proper desired effect with our aligners. And it's also very helpful in our non-growing patients because we would not be able to expand as much in those patients. So anteriorly, we can gain 3 millimeters of space, and posteriorly, we can gain 7 to 10 millimeters. There is a theory by Peck and Peck that if we had broader contact points, we would have more stability. And that's another indication for doing IPR. We learned in orthodontics that the best way to have stability is to preserve that intercanine width. So let's not deviate from some of our rules and remember that we cannot just expand to the point where we're violating stability. However, having broader contact points allow us to be more stable. It's like distribution of weight as if you're wearing a 120 millimeter stiletto, or if you're wearing a flat shoe. You're just more stable with that broader base. We know that when we violate that intercanine space, we do have a lot of relapse. But if teeth are properly positioned in the bone with proper torque and proper contact points, we will be more stable. Another indication is improved aesthetics. This is what drives most of us here. If we lengthen and broaden that contact point, we can bring that papilla downward, and this can decrease our dark triangles. If you sound the bone and you have the distance between the bony alveolar crest and the contact point, and you create that distance to be less than 5 millimeters, that papilla will fill in. So those poppy seed spaces or those dark triangles between the teeth will go away. And that's one of the things that most patients notice right away in themselves. And that's usually what most patients complain about. And as we age, those dark triangles increase. So having an easy way to make them smaller is really great. Sometimes we use interproximal reduction to avoid extraction. We talked about how we want to have that ratio between the upper and the lower anterior teeth. Here's a patient who is missing upper laterals, but we do not want to extract. We do not want to extract two lower premolars or take out a lower incisor. So how are we going to achieve a good solid bite with proper overjet and overbite and aesthetics? Yes, we're going to move the teeth around. Yes, we're going to fix some of the problems that you see in this composite picture. However, with interproximal reduction, we're able to achieve that. So what are some of our concerns theoretically with removing tooth structure? I mean, it is something irreversible, but it's a concern that we will be creating periodontal issues. We want to make sure that we're not promoting bone loss or we're having gingival recession. We want to make sure that we are not creating perio pockets. And they found, this is Arkton, Kokich, and Osterberg, they found that there were no negative effects here. We found that there was no increased risk of periodontal attachment, even when we brought those roots closer together. As long as those roots don't touch or you have some trauma from those roots, everything stays perfectly fine and healthy as long as we have proper home care. Obviously, without proper brushing, flossing, and diet. None of our mouths are stable, but as long as we keep those mouths clean, we are not causing any periodontal issues. There's also a theory that if we're doing this reduction and we're scraping and reducing the enamel, we're leaving a much more rough surface. Rough surfaces are more susceptible to plaque buildup. They did SEM studies and really analyzed at the molecular level, the microscopic level, what the surface was like. And they found that sometimes teeth after IPR were actually smoother than without it. And that polishing the teeth with the thinnest or smoothest of strip is actually very helpful. Are we increasing the risk of caries? We never want to do that. So in AJODO, they did a 10-year follow-up and they found that there was no increased risk of caries due to plaque, and there was no increased plaque when done properly. So what are some of the contraindications for doing IPR? If you take off too much enamel, too much of anything is never good. We don't want to do that. If you don't remove it properly and you create ledges or notches, again, creating unnatural anatomy. If you take off too much and cause tooth sensitivity, that is not advised. And you never want to damage any of the surrounding tissues, like the gingiva or the lips, or lacerate anything. So with proper use and properly treatment planned, we can have predictable results that are safe. And there is no evidence of long-term negative effects when properly done. So what can we achieve with proper use? It is a safe method to gain space and relieve crowding. We can correct tooth size discrepancies. We can improve aesthetics, and we can increase long-term stability. So how do we achieve IPR? There are multiple ways. One way is with this little fan that's on a handpiece that swings in between the teeth. For me personally, this makes me very nervous. Look at how close it is to the lip and the tongue, and all I see is a laceration happening. I'm sure for some people this is great. For me, it just makes me nervous, but you can achieve great results with this product. And this swings back and forth, and you have to just be careful that with any method that we discuss right now, that we do not create a ledge. Another one is with a wheel, just like this. And you can go in and out between the contact points and remove tooth structure. Again, be careful of the lip, the tongue, or any movement from a patient. Now, these discs also come with guards, and you can see right here how it fits in between. Just be careful that you're able to see exactly the angle that you're going in, and that you can see your contact point around this guard. Here's something else that came in. This is right up to a slow speed, and you actually put this little saw, and the saw goes back and forth. It's funny, this came in today, and it was on the counter, and one of my patients saw it, and they actually said, "What's with the saw?" Which what little kids see is what they say. Now, with all of these, we have to be careful that we know how thick we're going. Another way is using a mosquito burr. And the mosquito burr is very well controlled and very short, and you can really get in between. And you can really see how you can trim those teeth. Now, with all of these methods, you need to make sure that you know how thick you're going. And sometimes we have these strips just like this. And these strips go in between and you hold them. Now, these are a little bit longer, so you end up curling it a little bit like floss, but you have to make sure that the tails don't cut the lip. Sometimes you cut at the commissure, or if they, close a little bit as you're doing it, there's a little bit of resistance, so they kind of purse their lips a little bit, you can lacerate the lip. So be very careful with that. And they come in varying grits and in thicknesses. And here's one that's perforated. This is by Brassler, and you can get in there. One of the advantages of a strip versus one of the wheels is you can really bend it and contour to create a, make sure that you do not have any ledges, and you can create that nice soft anatomy that we all strive for. We need to make sure that we know how much we are removing. So there are some gauges, or I call them keys, of different thicknesses, 0.1 to 0.5, and you slide them in between the contact point to see how much you have removed, how much space there is. Now, sometimes it's hard to know if it's equal on one side, depending on where you've cut. Is it on the right hand tooth, the left hand tooth, where you took off more? And you need to be able to measure how much you need and how much you have achieved and how much more you need to reduce with these trimmings. Another option out there by Directa is the rainbow set, and it's really pretty nice because it's safe, because that little strip is contained by protection, and it also comes in varying thicknesses, coarse, how coarse it is, and also if it's on one or both sides. And here it's in a little box, so you can flip it up, and if you're going to achieve 0.25, or if you're striving to achieve 0.25, you can start a little bit smaller, break that contact, and then continue to go and remove tooth structure, and then go up to the next size up to get your achieved targeted amount. And here you can see how they're marked and colored. And this was me talking about it.
Hi, I'm Dr. Christina, pediatric dentist and orthodontist, and I love the rainbow set by Directa. I'll be working and chair side, my assistant will come up and I can pick between fine, medium, coarse, and double-sided or single-sided. So with our IPR strips, it can be totally safe. And not only that, when we do our IPR, you can actually bend a little and shape it so that we can have contour to our tooth. So that's why I love my Directa rainbow set. Thank you.
So with that contour, we can actually make sure everything's smooth, and we can know exactly how much tooth structure we are removing. So let's go into some cases. So this is Leslie. Leslie presented to me. She's in her mid-50s. And when you look at her in the top left-hand corner, you can see she has a fairly balanced facial aesthetics. Her smile is, facial thirds are very balanced. We see a lot of those upper anterior teeth and a very flat upper lip when she smiles. When we look at her profile, we can see she is clearly a skeletal class 3. There's not much we can do with that skeletal relationship. She's in her 50s. We are not doing orthognathic surgery, but she just doesn't like her smile. She has one of those smiles that, while the teeth may not necessarily look fantastic, she just has that inner brightness that comes out. So when you look at her smile in the bottom middle slide, we can see we have a very compensated class 3, but we have overjet and overbite, but we have a crossbite of the upper left lateral. We see that those lower anterior teeth are super retroclined. Those upper anterior teeth are also retroclined, but she has fairly solid class 1 occlusion. In the middle, on the right-hand side, we can see that omega-shaped arch when we look at the lower occlusal. And we look all the way in the middle to the left-hand side, we can see the upper arch is a little bit broader. She wanted to achieve a better smile and to fix that one tooth that always makes her feel like she can't have pictures taken from that side. We all have our good side. So here we are with our aligner ClinCheck, and we can look at our Bolton analysis, and we can see that we have 0.54 millimeters of mandibular excess. So even though our upper anterior teeth are in front of our lowers, we have too much tooth structure. Now I have to do some expansion of just uprighting those teeth and moving those teeth around and jumping that bite with that lateral incisor, but how am I going to achieve a good bite? Even if we forget about that crossbite, and if we look at the size discrepancy from the upper right one with the upper left one, 0.39, 0.2, it's a little bit, 0.1 millimeter off. But if we look at the laterals, 0.98, like 6 to 6.2, 0.2 millimeters is not going to give us that symmetry. So how will we achieve this? So on the left-hand side, we have our pre-treatment picture. And on the right-hand side, we have our simulation of where we wanted to go. And as I go through this presentation, the left-hand side will always be the pre-treatment image, and the right-hand side will be either the simulation or our final. And you can see how we really need to do something to fix these teeth. When we look from the side, we can see on the left-hand side how retroclined everything is. And as we bring the front teeth forward, the anterior teeth more upright, we're going to bump, and we need to resolve some of that crowding. We're going to look at the left side bite, and we can see where that cross bite is of the lateral. How are we going to have some place with less tooth structure on the upper fit in with the lower? And when we look at the occlusal, we know that when we look at those centrals that are overlapped, we will have a dark triangle there. So we're going to need to plan for some IPR. And how are we going to resolve this crowding on the lower left to create what we want on the lower right? And this is actually how we finished with her. And you can see she still has that skeletal class 3, and you can see her smile is just more aesthetic. When you look at the lower right-hand corner in the middle, at the lower arch, you can see that we've achieved some beautiful roundness and stability with those lower anterior teeth. They're still retroclined because I cannot torque enough in a patient like this, but we've definitely achieved better aesthetics by moving these teeth with aligners and gained some aesthetic points with the interproximals and getting these teeth to fix by doing interproximal reduction. This is Danny. Danny was 24 when he came to me. He's a golf pro, never had braces. His parents said, you're either getting golf lessons or braces. And he got golf lessons. When you saw Danny, he was a quiet, shy child, or not child, but 20-year-old, and you saw his front 2 teeth. When he walked in the room, you saw those front 2 teeth, and he came to me and he said, I just want to be able to smile. He was also lip taping because he could not close his lips when he slept. So what did we do? When you can see, he has fairly good aesthetics. The hair is always under a baseball or a golf cap, so we can't speak to the hair, but he is fairly, he's a cute guy, kind of looks like Rory McIlroy. And when you look in the middle left-hand side, we can see the shape of his maxillary arch is very V-shaped. And when you go in the middle line all the way to the right-hand side, it's very U-shaped. We have some lower anterior crowding. We have class 2 relationship, and number 14 is ankylosed and has some external resorption. But we can see that we know that if we tried to resolve this crowding by proclining, we are going to have black triangles, but also everything's going to be very flared. He's not going to have proper aesthetics, and it would just make him even less lip competent. So we needed to retract those upper anterior teeth, and we needed to expand posteriorly. When we expand posteriorly, it does retract the upper anterior teeth some. So we are also using class 2 mechanics to fix this case, but we're just going to look at the aesthetics here. Well, let's look at his Bolton. We couldn't do a full Bolton because we could not account for that number 14, but we have 0.73 millimeters of mandibular excess. Even though his upper anterior teeth are up and out, we still have too much tooth matter on the lower arch. So we really had to plan how we started and how we would end up. And we can see that we're striving for the picture you see on the right-hand side, and that would definitely require some IPR to help us move things along. And this is where we started on the left and where we were striving to achieve on the right. So we needed some IPR posteriorly to help us retract those teeth. Okay, and we did end up extracting number 14, but we did not want to extract bilaterally. And we can see we developed the shape of the arch from the left side to the right side. And we resolved our crowding, and it's much more stable. And we did take his overjet from this to overbite. Now that's more of orthodontic mechanics. We're not going to get into that, but this is how Danny finished up. Danny, once we got his smile much better, went from being middle of the pack to having the confidence to actually finish up in his tournaments first and second in the state. He's one of the top teaching pros in New Jersey at this time. And he tells me that changing his smile gave him that confidence and that he didn't feel like he was that goofy kid anymore, that now he was actually could be viewed as serious. So this is one of my patients' fathers that came to me just last week, and he had previously had 4-by extraction, and he didn't like the crowding that had occurred as he has aged. So he said to me, I really want to resolve this. Now we're already down 4 teeth. All first premolars have been extracted, and we need to plan on how to achieve better aesthetics and resolve the crowding. So you can see he's a fairly handsome guy in his 50s, but when we look in the middle right hand, when we look down at the lower occlusal arch, we have that crowding and everything feels kind of squished in. And when we go to the middle row on the left hand side at the upper occlusal picture, we can see that that arch symmetry is not necessarily there. Now, the important thing here is seeing how these teeth fit together. While he has a class 1 occlusion, those upper and lower anterior teeth just aren't fitting together properly because we are violating that Bolton analysis. And so when we look here, even though we've had 4 bys extracted, we have 0.85 millimeters of mandibular excess. So we have to get rid of some tooth structure or leave some space distal to the upper laterals to achieve proper overjet and overbite. And this is where we have some of our planning that we are dealing with. So what I'm showing you here is actually where we are when we started and where we are when we finished. And I just want you to look at the contact points. Now, the gingiva cannot really be simulated very well with this program. But look at the contact points, especially between 8 and 9 on the left versus on the right. And you can see when we did 0.3 millimeters of IPR there, we actually were able to create that broader contact point and have the simulated better gingival fill. When we look between the lower centrals, it's the same thing. We can see how we already have some black triangles between the centrals, but when we did our IPR there, we could resolve it. And here we just changed our arch shape with development, and you can see, even though we had spaces from the beginning, we did some IPR just to get everything to fit together better and look better. When we look at his lower crowding, again, we need to have some IPR to have everything fit. And here, this overjet overbite is actually really nice because we can see on the left-hand side, we're crowded and we're very tight or overcoupled. On the right-hand side, we are a little over-engineered with the upper anterior teeth overly proclined, but we can see how we have more clearance. Now, with our prediction, we will not get 100% of that overjet. We always have to factor in some over-engineering. If we predict to some movement, we usually get about 80% of that with torque, especially in an adult male on the upper anterior. So some of that is over predicted, but you can see how at least our ratios and our alignment is much better. And this is treatment without IPR, and this is treatment with IPR. I did a simulation just with that, and we can really see how, while the bite is actually the same, just trimming those contact points, squeezing those teeth together, and really reshaping things can provide from really good to great. And then this is Chris. Chris is a Green Beret who just left the military and actually just married a dentist. And he came to me before his wedding and he said, I need to fix this for my wedding pictures. Never had any braces, but he had a really nice smile. If we look at the top left-hand corner, we have very nice facial harmony, good proportions. When he smiles, we have a nice broad smile. We see upper and lower anterior teeth. We see tiniest little bit of gingival show, but he's very aesthetic. Now, if I had seen him when he was younger, I probably would have expanded him a little bit, but that is not an option. When we look in the middle row all the way to the left, at the occlusal view of the upper arch, we can see that there is not as much arch symmetry as we like, and the middle center picture shows us what's a very flat curve of spee and some crowding on the upper and lower arch. The lower arch is very, on the middle right-hand side is very tipped inward, and we can see we have some crowding. So we need to resolve this, and we need to have some nice aesthetics. When we look in the middle picture on the bottom where we have 7 and 8 overlapping, that always concerns us for a black triangle because of that position. Let's look at his Bolton. His Bolton was actually not too bad, with his upper right one being 8.7 and his upper left one being 8.6. We can see that we have a little bit of leeway there. But when we go to the lower arch, the lower right one is 4.9 and the lower left one is 5.1. So we can see a little difference there. Ironically, the lower laterals are exactly the same size as with the lower canine. So he has more symmetry than we like. However, we have 0.1 mandibular excess. Not too much. That Bolton discrepancy is pretty small. So I don't have too much to work with, but I still need to do some IPR to get everything to fit together. So here we have from the front, we know that we need some upper one in between 8 and 9 just to get some better aesthetics with that dark triangle. And with that crowding, we need to do some on the lower. By doing the IPR on the lower, we're also able to retract those teeth to help us get that, achieve that better overjet and overbite. When we look at the right bite, we can see how the lateral is flared forward in front of the central, which means we have to watch out for a black triangle there, although we have nice class 1 occlusion. And when we look at the other side, we do not have as many concerns about those upper anterior teeth. And you can see how we develop the arch shape on the upper occlusal view. And when we look at the lower occlusal view, we really need to resolve that crowding. There's no way I can move those teeth and slide them forward and keep them stable in bone without interproximal reduction. It's the only way for me to fit those teeth in. And you can see our overjet and overbite from before to our simulated at the end. And again, a little bit over-engineered, but this is what we're striving for. And this is what we achieved. Okay, you can see that he has a beautiful smile. We finished it up just in time for him to walk down the aisle, and his bride's dental friends all approved of this smile. And we can see how we have really nice midlines are on, we have no black triangles, and we have nice occlusion. Sometimes when our midlines are slightly off and we have that Bolton discrepancy and we know that one central is bigger than the other, we can reduce that way as well to help achieve our midline. So at the end of the day, interproximal reduction is another tool in our toolkit for how we can achieve our best smiles. It is extremely safe. It is a great way to gain space and to alleviate crowding. It helps us address tooth size discrepancies, and it helps us really provide that excellent aesthetics, which is just more than aligning teeth or doing our bonding or veneers just to get everything fit to fit. We reduce those black triangles, which are always a problem for every smile, especially in this zoom in on our phone pictures day and age. And it also helps us create long-term stability, because if all the books are lined up properly on the bookshelf, they don't topple over. And I say that when all of our contact points are aligned properly, our teeth are very stable. So hopefully we've answered some questions about interproximal reduction. This is our favorite team member, Callie. She's my certified therapy dog, and she sits on patients in the office, and she brightens everybody's day. If you have any questions, I will address them right now in the Q&A, but if any come up later, or if you don't feel comfortable asking in this forum, please feel free to email me. And thank you for spending time with me tonight.
All right, let's give everyone just a minute here to type in any questions they have. And I do see that we have 3 questions right now in the Q&A box.
Okay, so the first question that I received is, what are you going to do for the 50-year-old and for the golf pro for retention? Okay, so, and will it be indefinite? So I believe that retention is necessary for everybody. Every time we bite and chew and clench and speak, there are micro movements on our teeth, and teeth move. As we age, no part of our body stays the same. So wearing a retainer to move those little micro movements back into their original place is very beneficial. I use a clear Essex or Vivera type retainer for these, which also helps for the clenching. And they wear it when they sleep. It acts as a night guard and as a retainer, and it works quite well. So that's what I would do. For the 2 patients above, what did I use for expansion? Okay, so for both of them, when I looked, now I'm going to get into a lot of orthodontics here, but when I look at a case, I take a CBCT, so I'm looking at it from all sides, so I can see if I can upright the teeth on the bones, and making sure that I'm not creating any dehiscences, and I'm just keeping the teeth in the bone. And on both of those cases, that tipping or uprighting kept those teeth in a better position on the bone. And so I did it with uprighting. And that's what I did for both Danny and for Leslie. That would be the 50-year-old with the class 3 and with the golf pro. With the golf pro, there was also a lot of class 2 elastics to bring the mandible forward. The next question is, do you over-engineer overjet in all cases? By how many millimeters, and in the upper and lower arch? So it depends on what type of movement you're doing. If you are trying to torque your upper anterior teeth and cause buccal crown torque and palatal root torque on your upper anterior, you usually get about 70% of what you engineer. So I always over-engineer that in that case. And then the same goes for the lower. You're only going to get about 70% of your torquing. So yes, I do over-engineer by 30% for torque. It's one of the hardest movements to get in brackets. It's one of the hardest movements to get in aligners. Next question is, what factors increase the risk of black triangles during or after clear aligner treatment? The risk factors are, is there previous crowding? If there is crowding, there's usually some bone loss in between the roots of the teeth. So as you unravel them, you're actually raising the contact point. You're putting the contact point in a different position, which is increasing the distance between the contact point and the alveolar and your bone. Okay, so if you want that distance to be 5 millimeters or less, okay, so if you know you have very triangular shaped lower incisors or upper incisors, the anatomy of the teeth is also going, and the bone loss are going to be the two reasons, the two factors that I look for black triangles. Some people have very rectangular teeth, and those teeth, while you may have a little bit of bone loss, when they're crowded, when you unravel them, those black triangles are not as visible because that contact point is broader and because the distance between the contact point and the bone tends to be less, tends to be 5 millimeters or less. The type of retainer, they asked me to repeat it. That was a Vivera, or like a the clear Invisalign or aligner type retainer, also known as an Essex retainer, the suck down, a suck down plastic. The next question is, do you use bite ramps on my Vivera retainers? Bite ramps are case by case. If they tended to be a shallow bite or an anterior open bite tendency, no, I do not put bite ramps. But if they tend to be a deep bite case, yes, I will put bite ramps. The next question is there ever any problem with whistling with the overjet? I assume that question is with the over-engineered overjet. No, because you're not actually you're not achieving what we're trying to over-engineer. We're not going to achieve as much as we want. So no, if we ask for 1.5 millimeters of overjet, we usually get about 0.5 millimeter overjet. If you ask for a little bit more, you get a little, that proportion is always there. Let's see, anything next? Okay, here we go. Who carries the slow speed attachments with the guard over the reduction disc? You can get those at almost any supplier. I know that Shine, Darby, Patterson, all of them have that. The next question is, why do you like clear retainers better than Hollies for retention? Are Hollies out of style? And does it matter if you did IPR? What type of retainer would you use? So Hollies are not out of style. I think it depends on what you are striving to achieve. There are pros and cons for clear aligners and for Holly retainers. Clear retainers fit super tight because of scanning. So there is very little space for saliva. That means that the teeth can become slightly dehydrated. And if the teeth are not clean, if they've consumed anything other than flat water and have not brushed, you're packing very tight aligners or retainers onto the teeth and packing that sugar onto the teeth. The other thing is if they have brushed and flossed, but the retainer or the aligner is not clean and you're putting it on the tooth, you're actually packing acid right against the teeth. So you actually are at a higher risk of cavities if you do not have clean teeth and a clear aligner or retainer. And you can have what we call the aligner decalcification pattern, where instead of just having cavities interproximally, we're actually getting them on cusp tips and buccal and lingual surfaces because the acid and plaque is being pushed right up against those teeth. Hollies allow more saliva to go in. So they are a little more hygienic in that fashion. The Hollies can be a little bit harder to speak with, and clear retainers, because they do fit tighter and they do not cross the palate, can be easier to speak with than with the Hollies. if you want to have an anterior bite plate that needs to be thicker because, meaning further back because you may have a class 2 occlusion, you can't get that length or how wide that anterior bite plate is with your bite ramps on your Vivera or on your clear aligner. So if you need a very long, broad bite plate, you're better off with a Holly. As with everything, there's no one size fit all. And that's the important thing, is to know the pros and cons of each appliance and use that. Children now, or patients now, I should say, prefer the clear aligners, clear retainers, just because they are easier to speak with and easier to adapt to. Sometimes it's the best choice for the bite, sometimes it's not. Next question is, if IPR is needed midway through treatment and the teeth are slightly mobile on the lower anterior teeth while doing the IPR, is this a concern or is this normal? I think the first thing is, what is the etiology of the mobility? If we're moving teeth through bone, teeth are always a little bit mobile. We're talking like +1, maybe 1.5. If they're mobile because of a perio issue, that is a totally different scenario. And all teeth being moved need to have perio clearance prior to moving them. So you should never be moving teeth in a case where there's a perio problem. Okay. And we need to move teeth into solid bone. So first indicate why we are having that mobility. Okay, so some mobility is normal. I mean, you can't move a tooth through bone unless there's some movement. So that's something to think about. But definitely, if you're finding mobility that's more than it should be, talk to perio, slow down your movement, the way you move the teeth, how quickly you move the teeth, all of those are factors into that. But you want to be careful. Now, sometimes you need to do a little IPR when there is a little bit of mobility, because the friction between the tooth is actually contributing to that mobility. So that is really not a very straightforward question or answer in that case. And then here we go. How much do the teeth settle so the bite closes? I don't know what type of bite closure you're talking about. If you're talking about posteriorly, where sometimes we get a transient open bite just from the thickness of the plastic between the teeth, that type of an open bite will close very, very quickly. If it doesn't settle, which is decreasing the amount of wear that you're having, you can trim the aligners so that you have anterior contact and just allow the posterior teeth to settle. Or if it's really not closing on their own, you can add buttons posteriorly and box elastics, and that will close that posterior open bite fairly quickly. I think we are at 9:30, 9:29, and I think we are out of time.